Pituitary apoplexy is an acute endocrine and neurosurgical emergency caused by sudden hemorrhage and/or infarction of the pituitary gland, most commonly occurring in a pre-existing pituitary adenoma. The rapid expansion of the gland within the confined cell interstitial leads to compression of surrounding structures and acute pituitary dysfunction. Definition: Pituitary apoplexy refers to the sudden hemorrhage or ischemic infarction of the pituitary gland, usually in a patient with an existing pituitary adenoma. It presents abruptly and requires immediate recognition and treatment. Clinical features: patients typically present with a combination of neurological, ophthalmic, and endocrine manifestations. 1. Severe headache. The headache is sudden in onset and is often described as severe or thunderclap-like. It results from rapid expansion of the pituitary gland and stretching of the diaphragm ocelli. 2. Visual disturbances. These occur because the enlarged pituitary compresses the optic chiasm or the cranial nerves within the cavernous sinus. Patients may develop reduced visual acuity, visual field defects, classically bitemporal hemianopia, diplopia due to cranial nerve 3, 4, or 6 palsy, ophthalmoplegia in severe cases. 3. Pituitary hormone deficiency. Acute damage to the pituitary gland may impair secretion of several anterior pituitary hormones. The most urgent deficiency is ACTH deficiency, which leads to secondary adrenal insufficiency, hypotension, nausea and vomiting, weakness, hypoglycemia. In severe cases, circulatory collapse. Other hormone deficiencies TSH, LH, FSH, GH, and occasionally prolactin may also occur. Diagnosis: MRI. MRI of the pituitary with contrast is the imaging modality of choice because it can demonstrate pituitary enlargement, hemorrhage or infarction, compression of the optic chiasm, extension into the cavernous sinus. Baseline endocrine investigations should also be obtained, including serum cortisol, ACTH, TSH and free T4, prolactin, LH, FSH, and sex hormones, IGF-1 when appropriate. Treatment: management should begin immediately, even before complete endocrine evaluation if pituitary apoplexy is strongly suspected. 1. Acute management. The first priority is urgent glucocorticoid replacement. Intravenous hydrocortisone is the treatment of choice. It treats acute secondary adrenal insufficiency and helps stabilize blood pressure and overall clinical status. Supportive measures include intravenous fluids, correction of electrolyte abnormalities, close monitoring of neurological and visual function. 2. Surgery. Urgent transsphenoidal decompression is indicated when there are progressive visual loss, severe visual field defects, deteriorating ophthalmoplegia, declining level of consciousness or significant neurological deterioration. Patients without significant neuro-ophthalmic deficits may sometimes be managed conservatively with careful monitoring. 3. Long-term management. Following the acute phase, patients should be reassessed for permanent hypopituitarism. Long-term hormone replacement may include glucocorticoids if ACTH deficiency persists, levothyroxine for central hypothyroidism, testosterone in men or estrogen progesterone replacement in women, growth hormone replacement in selected patients. Regular MRI follow-up and endocrine assessment are recommended.